Hi, I'm Alan Boone, Board of Director for AAST, and welcome to today's session. Today we have Julie DeWitt and Christina Weaver, and our discussion is going to be concerning patient care, primary care physicians versus sleep medicine specialists. Julie's brought a number of items from her employment concerning different statistics looking at how patient care is handled in her facility. Julie, would you like to discuss it?
What we do is we utilize what's called a closed loop system. And what that is our sleep team is managing the patients. We use automated platforms, and we're providing a continuous end-to-end care for our patients. It helps with patients not falling through the cracks, so to speak, and we're able to follow up and manage these patients constantly, and especially the patients that are having difficulty. So we can monitor, for instance, their CPAP compliance, and we know if this patient is struggling, and that's somebody that we need to focus on and bring them back into the office, see what's going on, help them. Maybe they need a different mask, maybe they need a pressure adjustment or a desensitization appointment.
Christina, I know you have quite a bit that you'd like to share with us.
We have managed at our hospital a sleep navigator program, and it all started about 5 years ago where Medicare was reimbursing or not reimbursing for readmissions. So if a patient gets admitted into a hospital and sooner than 30 days later they get readmitted, let's say for atrial fibrillation, the hospital does not get paid. So what we see from sleep apnea statistics is there's a 70% reoccurrence rate if you have AFib and untreated sleep apnea. So what can we do to decrease that readmission? We started screening with different comorbid conditions, heart failure, cardiac arrhythmias, resistant hypertension, diabetes. And what we saw was 86% of the patients that we screened in that first year, 86% of these patients were diagnosed with sleep apnea. 44% had severe results, and in that first year, we had a 38% reduction in readmission. So in that first year, 38% consistently for the next 6 years, we kept it above 30% reduction. That saves the hospital money. It's a better quality of life for the patient. And one of the big things that we realized by doing this program is there were a lot of conditions that the patients probably had sleep apnea for so long that probably caused that original AFib. And therefore they came back in multiple times. And finally, once we treated the sleep apnea, something that was missed with that patient's primary care physician for years, we identified it, found it, and they stopped getting readmitted.
Can you think of any potential shortfalls that may be inherent in the system that you're working to improve? And really, that's for both of your programs.
I think one of the biggest things I see is the lack of awareness from the primary care physicians and specialists. They think the word sleep apnea, that sleep undervalues really what the disease is. It's not a sleep problem. It's a respiratory and cardiac problem. So it is a more severe disease, and it's more impactful than I think what a lot of physicians really think it is, and it's very difficult to manage.
Now, to this, it's kind of a little bit of a historical perspective on this. Was there any one piece, any one incident that precipitated your programs to initiate this? Was there a particular instance, or was it just kind of a build up to critical threshold that you saw the need and decided to implement this?
Well, what we saw was prior to becoming a closed loop system, there was not as many studies being done. The referrals weren't being managed appropriately, and neither were the patients. So we went from doing maybe 100 visits a month to now we're at 4,000 visits a month. And we're now receiving over 1,400 referrals a month in our facility.
But I think that one thing, and I just want to add into this, for me it sounds that it's not just adding more numbers to it, but you're adding higher quality visits in the process. They're becoming with a greater productivity to the end. Is that a fair assessment?
It's very fair. And we actually have PowerPoint presentations. We bring people into a group setting and we do a PowerPoint presentation on what is sleep apnea. And we go through that with them so that we can educate them first. And then we'll set them up with maybe a home sleep apnea testing, and then they'll come back the next day. If they're positive, we'll send them out on an auto-repeat trial for CPAP titration, and then they'll bring that back after 7 days. And then if they are showing good results and they had good compliance, then what we'll do is we have our dispensing crew and we send them over there to get their equipment dispensed. So they can go home with their equipment same day, not have to wait a week or two.
I think it all comes down to a lot of it, the primary care has such a limited time with that patient, and the going to a sleep specialist and somebody who that's their specialty, we have a lot more time to follow that patient through. You know, a prime example, one of a big initiative that they're making for joints, for example, is prior to an elective joint surgery, they're encouraging and seeing a cost reduction in going to a joint class, learning about what is that surgery, how to prevent it, get in rehab, and then once they get out, they're following through with better rehab, and it's that continuum. I think the same kind of follow through should be for sleep apnea. There's a lot, it's a life-changing to get diagnosed with a sleep disorder. So not just sleep apnea, but a sleep disorder. And we have a lot more time being specialists to be able to do that. We also have an initiative where any patient that is placed on CPAP, we want to call those patients in that first week of usage. Our goal is 100% because we know that those patients are going to be more successful. They're going to be more compliant. By doing that, that patient's encouraged, knowing that we're watching the new online modems, knowing that we're clinically making sure that their sleep apnea is treated, they're not having residual apneas within that first week. If they're having problems within that first week, if we can correct them right away, they're going to long-term be more successful.
If we could, let's go back for a moment and touch base on the insurance coverage again. And during the break in our conversation that you both mentioned that your facilities operate under different conditions. Julie, can you tell us about yours?
Yes, we're an HMO facility. And so our patients, depending upon the plan that they have, some of our patients may have a deductible plan and they will have to meet their deductible, and then other patients do not, and they just have a simple copay that they have to pay. So we're considered specialty, so it's going to fall under that specialty copay.
Okay, and I'm sorry, but I'm going to take this just one step further. That also is making me take a look at, I'm sure that this is all operated under a highly integrated electronic medical record system,
Yes, it is.
EMR system.
It is. We do utilize EHR for electronic health record, and everything is integrated together so that we can find all of this information. And we do use a third-party software that has our records from the sleep center talk to the medical record. So when we pull a patient up, we see everything from beginning to end on all of their care in the facilities, not just sleep.
Very, very nice. Christina, can you tell us about yours?
Our hospital system is an accountable care organization where we're very involved with the cost overall of comorbid conditions and lowering those costs on readmissions, lowering the costs on certain bundled pricing initiatives. So, for example, a heart failure patient, if they come into the hospital and they stay a lot longer than what the 3-day rule is of what insurance will pay, that rises the healthcare cost. And if they keep getting readmitted, let's say, because they have untreated sleep apnea, then that readmission cost rolls up into that whole bundled price initiative, and it actually costs the organization a lot more money, and the patient suffers as well. So we look at a very integrated network to get a team of specialists involved in that patient's care to lower the costs and raise up the quality scores, and basically be a little bit more preventative instead of reactive with the patients.
So I would think there would be a great interest on making sure that the correct diagnoses or the most influential diagnoses are picked, and then paying particular attention into the comorbidities along those lines.
Definitely. You know, one of the things that physicians sometimes could get graded on is their quality scores. Let's say, for example, resistant hypertension. If they have a lot of patients in their cardiac office that is taking a ton of high blood pressure medication, that can show that they cannot manage the high blood pressure. Let's say they have a bunch of sleep apnea patients and they're not talking about sleep in their practice. That physician quality scores is going to go down, and then the hospital cost is going to go up because those patients have high blood pressure. They're going to get readmitted.
Yes, it's always very eye-opening. So, ladies, thank you very much. I very much appreciate you coming in and participating in our series. And again, thank our audience for this. And we look forward to seeing you online again, and we'll see you in our next presentation. Good day.